Hi, everyone, and welcome back to our next episode of ReWalk's Topics in Neuro Rehabilitation webcast. I'm Jill Butler, and today we'll be talking with Chief Medical Officer at Encompass Health, Dr. Lisa Charbonneau. Dr. Charbonneau was appointed Chief Medical Officer of Encompass Health, formerly HealthSouth, in June 2015. Prior to that role, she served as the company's Vice President for Medical Services. From 2001 to early 2015, she served as Medical Director at New England Rehabilitation Hospital of Portland, a joint venture of Maine Medical Center and Encompass Health, where she held a staff physician position since 1992. She served on numerous committees at Maine Medical Center, where she was the Director of the Division of Rehabilitation Medicine. She was a member of Encompass Health's Physician Advisory Board for over 10 years, and in 2007 and 2012, she was named Encompass Health's Medical Director of the Year for her outstanding clinical knowledge, exemplary performance in the development of quality clinical programs, and overall excellence in leadership. In 2020, Dr. Charbonneau was named to Modern Healthcare's list of the top 50 influential clinical executives. Dr. Charbonneau's talk today will demonstrate that rehabilitation is an essential service, and we'll dive into how Encompass Rehab, which is the national leader of inpatient rehab hospitals and home-based care, has continued to deliver high-quality care amidst the global pandemic. This is such an important topic right now, and to our viewers, I'm excited for you to hear about the great example Encompass is setting and potentially apply some similar precautions to your own practices. Please feel free to add your comments or questions below, and please remember to like and subscribe to this series if you want to see more talks like this one. With that, Dr. Charbonneau, I'll let you take it from here.
Thank you very much for the opportunity to present to you today on this topic of rehabilitation and recovery amid the COVID-19 pandemic, which has been certainly a challenge for all of us in healthcare. Just a little bit about Encompass Health, our company. Currently, we own 136 inpatient rehabilitation hospitals across the country, and we also have about 245 home health care locations and 83 hospice locations. So we are currently in 38 states and Puerto Rico. And our mission really is to drive high quality, cost-effective, integrated care across the healthcare continuum. We are actually the largest owner and operator of inpatient rehabilitation hospitals, or IRFs, as CMS calls us, inpatient rehabilitation facilities. And about 48 of our hospitals operate as a joint venture with an acute care hospital partner. And 124 of our hospitals hold one or more disease-specific certifications. Most of our hospitals have disease-specific certification in stroke, for example, from the Joint Commission. We have over 30,000 employees and treat almost 200,000 patients a year in rehabilitation. In terms of our home health and hospice business segment, we are actually the fourth largest provider of Medicare certified skilled home health services, and in the top 11 provider of hospice services as well. So we do have the ability to coordinate our inpatient rehabilitation segment with our home health and hospice segment to create seamless transitions for patients that are interested in that and have that available in their area. And that has also enabled us to do some really exciting programmatic enhancements involving those two business segments. So with the onset of the pandemic, I think an important thing to note is that the world shut down, but we did not. We continued and have continued all along to provide rehabilitation to patients who are recovering from a severe illness or injury that requires rehabilitation despite the pandemic. For example, many of you probably have heard that there was a significant drop in patients showing up at the emergency department with heart attacks and strokes, for example. But we know that people did obviously not stop having heart attacks and strokes during the pandemic. And we feel very strongly, along with our acute care partners that treat these patients, that it's very important to seek care urgently in the event of someone having symptoms of a heart attack or a stroke in particular, because there are interventions that can be done early on when someone presents with symptoms of a stroke, for example, and if they wait too long until the stroke is completed or further along, those interventions are no longer available to them and can affect their long-term recovery. So stroke patients, just as always, need rehabilitation, and we know, and it's well established in the literature, that the earlier you start rehabilitation for someone who has suffered a stroke, the better their long-term outcome is in terms of recovery of function. And that's due to the early neuroplasticity that we see with patients after they've had a stroke or any kind of injury to the nervous system, actually. In 2016, the American Heart Association and American Stroke Association got together and published clinical practice guidelines, which basically said just that the best place for people to get inpatient care after a stroke, if they need rehabilitation, is in an inpatient rehabilitation hospital or an inpatient rehabilitation facility rather than in a nursing home. And the reason is that the expertise that you'll find in an inpatient rehabilitation hospital are just more in tune with having a higher standard of practice for treating these patients, and also that there is more 24/7 availability of nurses and physicians who have expertise in rehabilitation and specifically expertise in treating patients who have had a stroke. And that's one of the reasons why we really support our hospitals in obtaining disease-specific certification in many of the neurologic areas, so that the teams that are working with these patients and treating these patients have additional education, which is born out of an increased interest in treating these patients and helping them recover from neurological injuries. So when the pandemic hit, obviously we had to look at how we were managing in our hospitals and making sure that we were doing everything for our patients and our staff to protect them from catching this virus, the SARS-CoV-2 virus, which causes COVID-19. We were very fortunate in the sense that we already had established kind of an out-of-the-box solution to infection control that was specific for an inpatient rehabilitation hospital environment, because we had noticed several years ago that there were guidelines for long-term care facilities and there were guidelines for hospitals, but there was really nothing from the CDC that was specific for an inpatient rehabilitation hospital. So we already had a very strong infection control protocols in place. However, the pandemic obviously shone a light once again on making sure that we were really paying attention to those protocols and that everyone was aware of the protocols and what we needed to do in this instance to reduce the risk of infection. So for example, all of the equipment in our therapy gym is cleaned in between patients and thoroughly at the end of the day. Fortunately, this virus has been shown to be very susceptible to what we were already using as cleaning solutions and supplies. And so it was just a matter of making sure that we were really diligent about going through these processes. We do continue to provide therapy in the gym. However, the way that we're doing that is very different. So we are maintaining social distancing recommendations, and that those are followed by our patients and our staff. Obviously, everybody is masked in order to have universal source control to reduce the risk of spreading the virus. And we actually stopped doing group therapy immediately when the pandemic became an issue. We closed our self-service areas and our cafeterias. And we also initiated all staff and visitor screening every day for exposure in accordance with the CDC guidelines. So looking for signs and symptoms, obviously, of illness or exposure to illness, or initially it was also international travel prior to being allowed to even enter the hospital. Our patients are evaluated before they even come to our hospital for potential infection with COVID-19. And then again, at admission, they are reevaluated again for exposure by our nursing admission staff. We also continue to evaluate during the day of potential signs and symptoms or changes in condition that could be attributable to COVID-19 or any infectious process. And we have masking policies in place for all staff and the limited visitors that we have allowed in the hospital, which initially was just no visitors, and then we were allowing one visitor only if they needed training in order to allow the patient to get home safely. And then that was done with extreme caution. The pandemic, if nothing else, has reinforced to us the importance of our level of care in treating patients who are recovering from COVID-19. We were able to find out that these patients actually are excellent rehabilitation candidates and do very well. And we have been able to treat them and get them home successfully after a course of rehabilitation. What we have found is that patients recovering from COVID-19 usually have been in the hospital for an extended period of time. Often they have been on a ventilator for weeks. And we already knew that patients who are critically ill in the intensive care unit have a preponderance of difficulties as they get discharged from the intensive care unit. And research has shown that 70 to 100% of these patients have significant cognitive issues at the time that they're discharged from intensive care. And at least 50% of patients treated in intensive care will develop significant neurological issues such as critical illness, neuropathy, or myopathy. So the effects of COVID-19 on patients are really widespread. And you can see in this schemata that we have not only respiratory issues to deal with in patients who develop COVID-19, but significant neurological issues. They are at a higher risk of developing delirium, stroke, headaches, encephalopathy, and falls. They have gastrointestinal symptoms such as diarrhea, nausea, and vomiting, loss of smell and taste, both of which can cause a loss of appetite and cachexia. They have a lot of muscle wasting and myalgias and have been found to have low albumin as well. The result of the cytokine storm that they experience while they are critically ill is very significant and can lead to long-term muscle wasting or sarcopenia. Also, these patients have significant cardiac issues and peripheral vascular issues, and many do develop kidney problems acutely. What we see in rehabilitation in terms of patients recovering from COVID-19 are significant mobility deficits. They get really short of breath with exercise. They're significantly weak and have muscle wasting. They have lost their appetite due to a loss of taste and smell. The cough that they have initially presented with can persist really for weeks or even months, even though they are no longer infectious at that point. Patients complain of feeling fuzzy in their head and having difficulty remembering things. They're isolated. Many of them have not seen their family or loved ones in many weeks and have developed significant anxiety and depression and even PTSD from their time in the intensive care units. They have difficulties with activities of daily living and self-care, as well as swallowing issues from their prolonged intubation. So rehabilitation really helps these patients by addressing these deficits in terms of their physical, cognitive, and behavioral deficits. What we do in inpatient rehabilitation is aggressive physical, occupational, and speech therapy to treat these deficits to enable patients to become more independent and regain their ability to function in the community again. One of the differences in inpatient rehabilitation and at our Encompass Health hospitals is that we are very used to dealing with patients who are more medically complex. We provide round-the-clock nursing. We have respiratory technicians who can address breathing concerns and issues. We have frequent physician visits, usually daily, and all of our physicians have special expertise in rehabilitation care. Many of our patients opened separate COVID-19 units when they found that they had a certain number of COVID-19 patients, and that enabled them to really cohort patients appropriately and provide staff with specific dedication to treating those patients. So we had units where there were nurses and therapists who were just designated to working with COVID-19 patients. And we would provide a spotter or a runner to help them if they needed to get something that was not on the unit, or to make sure that they were donning and doffing PPE appropriately. And in those cases, therapy was usually conducted in the room, but we did have some of our larger hospitals, for example, in the Northeast area early on, where they were able to actually have a gym just dedicated to COVID-19 patients. So our nurses in rehabilitation, many of our nurses have the CRRN certificate, which is a specialty certificate for nurses who have expertise in rehabilitation. And they are really a crucial part of the team, not just for routine nursing care, but really in helping with the rehabilitation needs of these patients. All of our patients have a case manager to help with discharge planning and transitions of care. We have physician oversight by physiatrists or other doctors who have specialized expertise in rehabilitation. We provide psychological support. All of our hospitals have infection control practitioners in-house, as well as respiratory therapists. And both of those disciplines are so important, especially for treating patients who are recovering from COVID-19. We have an in-house pharmacy, and our pharmacists are part of the team and really work with the patients on education about their medications and help the other disciplines with those issues as well. We have dietary support, and we do nutritional assessments on all of our patients at the time of admission. So we also have multiple disciplines of different physician consultants who are able to help us manage patients medically when they are more complicated and need that intervention. During the pandemic, we have been able to use telehealth and telemedicine specifically, and that's been very helpful with getting some increased expertise availability to our rehabilitation hospitals as needed during the pandemic. And so I want to thank you again for the opportunity to discuss how we have managed during the COVID-19 pandemic and continue to do so. and certainly hope that this does come to an end and we can kind of get back to a normal life sometime soon. Thank you very much.
That was great. Thank you so much, Dr. Charbonneau, for sharing all of that with us. Some really helpful information to help, I think, all of us, like you said, start getting back to our normal routines, and a good reminder of how important rehabilitation is throughout whatever is happening in the world around us.
Thank you very much.
So you sort of touched on this during the presentation, talking about distancing in the gyms and stopping group therapy you mentioned. But is there anything else specifically that your team is doing in terms of treatment algorithm changes where COVID-specific precautions are coming into play and changing how they're delivering their care from a rehab standpoint?
Well, I think the biggest change for our teams and our patients during the pandemic has been this change in how we are interacting with our patients. So we have had patients who, for either reasons that they're unable to tolerate a mask or unwilling to wear a mask, that need to be treated just in their room. And that combined with the absence of family support, often not seeing their families and not having their families there with them during the day, has taken a toll on our patients in terms of their mental health often. And so those are areas where we've had to kind of pay extra attention to help support patients through their rehabilitation. And that's been a big change. And also our ability to use the gym as we normally would. Normally you walk into the gym in the middle of the day and it's full of people and activity and lots of patients and lots of therapists and everyone in this big space together. And that is just no longer being done. So it's a big adjustment for not only the patients, but for our therapists to have to practice that way and think about when they can bring somebody to the gym and figure out how many people can be in the gym at one time and work out all those issues in terms of transporting patients and administering medications on schedule and that sort of thing. So it's added certainly a layer of complexity that is not insurmountable, but different from the way we normally provide rehabilitation.
That's awesome. Thank you so much. I think that's a really comprehensive view, and we're so happy to have had you with us.
My pleasure. Thank you so much.
To our viewers, we hope you've been finding these talks interesting and helpful. We're going to continue on with our monthly posting schedule, but in the meantime, definitely go back and make sure you've seen all previous talks and let us know in the comment section if there's any topics or speakers that you'd like to see in the future. Thanks so much for stopping by. See you again next time.